Right. Good morning, good afternoon, and good day for everybody. This is the final session actually for the MedInfo, and we will witness three events in this particular session. One of them is a panel discussion between the FEMA and WHO ICD-11, ICD, API, and for that, we have Dr. Robert Jacob, who is actually at the unit of, he is the unit lead for the classification, terminologies, and standards in WHO headquarters in Geneva. He is responsible for all aspects relating to classification and health information standards, leading the WHO network for the family of international classifications that compromises collaborating centers, NGOs, and the partners, and all the work of ICD. Dr. Jacob started in 2005 as a medical officer at WHO in charge of ICD and derived the classifications. And then he became the lead of that unit. We have as well Vicky Bennett. Vicky is the head of metadata and classification unit at the Australian Institute of Health and Welfare, where she has held a number of different roles over the past 14 years. She has also lectured at a range of Australian universities and is passionate about ensuring that good health information is used to improve health outcomes for all. Without any further to do, so the first session will be a panel discussion between on the ICD-11, and then we will have announcement of the next MedInfo, which will be in Australia, that has been postponed because of the COVID. And then we have the formal closing session of the MedInfo for this virtual session and the online. So I would like to invite Dr. Robert Jacob to make a presentation, and then Vicky, and then we will have a discussion, and then we announce the next MedInfo and then the closing. Dr. Robert, it's your role.
Thank you, Najib, for the lovely introduction. So then let me directly start about ICD-11, some structural design elements and the role of the API. Just to remind everybody that ICD-11 is not something that we have by choice, but it's international regulations that mandate its use for all purposes of mortality and morbidity, recording and reporting. It's a conceptual framework independent of language and culture. It has been around for 150 years, ensuring comparable longitudinal and vertical information studies. It allows now, with its new revision, the lossless clinical documentation, so you can code all the detail you want, and we'll see more to this later. And it's also an integration of terminology and classification in contrast to the past. It comes with an end-to-end digital solution with API, tools, offline and online use. And of course, with this revision, we have up-to-date scientific knowledge. To be noted at the beginning is also that ICD-11 is distributed with, as its siblings are, under Creative Commons license. Details you will find on our website. Just to remind everybody that ICD and ICD-11 and 10 are sharing some commonalities. That's what you see here in the circle. So some core, that is the statistical core, that has different levels of detail that can be coded. But what's different in the 11 is really that we are having under this deep, broad information that is the statistical core, a more detailed information structure with cross-references, multiple parenting, and many other aspects that then allow that these 80,000 entities and all the synonyms that are in there can be used by the tooling environment to understand more than 1.6 million formalized terms. And so really ICD has become no longer a purely statistical system that is imposed on the clinical context, but rather a clinical system that can be used for statistics. Now, getting closer to what I want to say this time is really, we have the functioning classification, the ICD, well known, and the interventions classification, the so-called ICHI. All of these are now in a common foundation that has a similar structure to what we have seen in the earlier slide, but it also contains what we call extension codes. So these WHO terminologies, some of which are totally unknown, others are maybe a little bit ignored, and others are a little bit newer, like, for example, severity. All these detailed extension codes allow to refine the concepts of functioning or of disease, injury, encounters, and other things that are in ICD, or also the health interventions. Of course, there are links to other systems, like we have it for related classification systems and also other terminology and instruments that we are working with. Now, the ICD has what we call a content model, and we had explained this before. Now, this content model has been adjusted so that it's extended to be usable by the ICF for the functioning classification and the interventions classification. And essentially, it defines core properties shared across all these classification terminology systems. And this has two systems. So one is the post-coordination model that formalize what the properties role is, and it provide a mechanism to do the coding with the use of these extension codes. And then we have, of course, then the linearization model that says on how we create this classification structure from this kind of ontological core. And so we have here a logical model that combines multiple codes. So a basic statement is certainly we have a concept that is a manifestation or has an agent. The same thing applies to the health interventions with different targets or more detailed anatomy. But then we have, what is the interesting thing, sanctioning rules that say, what are legal combinations of these extensions, either of main concepts or of concepts with extensions. That's the one way of expanding the system. The other way is to have logical combinations. So where one entity is kind of logical defined by a combination of categories. How does this look like? So in the authoring environment, this essentially means that, for example, as we see here, we have an ICD category that allows post-coordination access. In this case, we see here the severity of compromised lung function, a temporal pattern, and the lung itself as an anatomy, and eventually subparts of the lung then can be used. On the other side, we can make what we call these logical definitions, where we say, okay, this special asthma that is mentioned here, mild persistent asthma, may not have a single statistical code, but if you want to express it, you can use the category relating to asthma, and if you add mild and persistent to this entity that is in the foundation, then you get the code sequence. So what does the API do? The application programming interface and its underlying structure essentially use, of course, the full information that is the foundation, that's the statistical information, but also use all the additional information of the foundation. Besides that, of course, all languages are also exposed there. But when we do an API search, a call for information where we get text returned or the URI returned, you get results coming from the foundation entities that are more detailed than the statistical combination. So the system will find some kind of maybe clinically not so complete formulation like cholera-L-TOR as cholera due to cholera-L-TOR with code combination. And the other option is really that we have these post-correlation instructions that we have seen before that allow the system to understand that if you type in lung cancer left side, then it will find the code combination. If somebody is really interested in this, we have this Swagger website where you really can play with the calls of the API, and more instructions are on the API website so that you can get experience on what happens when. And what does this whole thing mean? Well, you already have the rendering in the outputs of the current coding tool, for example, that is using exactly this API where you enter this term Spigelian that is part of the foundation, and you can choose then the content that you are interested in. Of course, the statistical code, unfortunately, is just other specified hernias. Clinically, this is not satisfactory. And so if you choose the term, the newest version of the API will in the future be able to get the foundation URI so that in your documentation system, you can use both information and retain the clinical detail. And here we have the example where we have this kind of logical definition in the foundation where the system immediately identifies, the cholera L-Tor is a cholera due to Vibrio L-Tor, and gives you directly back the code combination, so the main statistical one, and here in blue, the extension code starting with an X. The API, of course, can address multiple versions of ICD-11, has a different language version, different releases can be accessed, and it can allow you to access the full foundation as well as specific linearizations of this statistical core, the MMS. And in the future, it will return automatically the URI in post-coordination single target foundation URI. At the moment, this requires a separate call of the system. Now let's look a little bit what the means for the ICD use. So in ICD-10, you had extensive use of the ICD index, and then you check in a tabular list, you know all the rules. Whereas in ICD-11, you have the coding tools, you follow a few instructions, and then essentially you are done. And actually from what we know from our testing, the results are very good. The same for ICD-10, we have fill in the courses on a paper certificate. In some countries, it's electronic already. And then you select the underlying course following the instructions in volume 2 of the classification, unless you are using a coding system like the IRIS. For ICD-11, we are digitalizing this kind of rule sets, as well as we are writing specifications how to design an electronic death certificate so that tooling that comes with it can be used with different certificates dataset created. Then in 10, of course, in ICD, that's frequently not so known. We also have definitions on how to record and report treatment episodes, what minimum detail is necessary. And in ICD-10, you would read the book as usually, follow the rules in the book. And in 11, of course, we are working, number 1, to have these rules for selection of the main diagnosis. And then we can see the rest, whereas we are also want to make sure that clinical documents, electronic clinical documents, record diagnosis and interventions in line with ICD, so that epidemiological reporting is still usable from the individual data rather than doing experiments. And this content, really, it's important to bear in mind that the ground truth is what the physician states as a diagnosis or as intervention of the patient. Then come ICD rules for coding, the coding tool, or intend the index. And then this ensures that we have comparable ICD coded content. And that's why we are also emphasizing all the time, ICD-11 must not be used as a downloaded list in some systems, because you will missing post-coordinated information, you will missing language standardization, you will missing synonymity, and maybe we need even to rethink on how we consume terminologies in modern information system. And with this, I'm coming to an end after this short, very short overview, and just remind you that our classification systems are there for you, and they will take advantage of your input. The whole thing for comparable health information to improve health of all people. Thank you very much.
Thank you very much indeed, Dr. Robert, and for this overview of ICD-11. It's a major change that I can see from ICD-10 and the way that it is dealing with terminology. And what you have said, the last statement that you made in terms of using the information and its classification for policy, for decision, and for improvement of health outcomes for the patients, for people. Let me call for another presentation on the same by Vicky Bennett from the Australian classification unit and she will talk about how they deal with that, and as she has a degree in health information management and she is an expert in metadata. I know for a fact that there is the Australian version of ICD-11 of ICD-10. I don't know how you are dealing with that in Australia, but you are in a fantastic position to tell us about that in terms of how you are advancing, how you are actually using ICD-11 in the context of what you are doing in Australia for classification of diseases and classification of the numbers for the sake of patients as well. So the floor is yours, Vicky.
Thank you very much. And yes, in my day job, I work at the Australian Institute of Health and Welfare, and we are a collaborating centre with WHO for the family of international classifications. But today I'm actually presenting on behalf of IFHIMA, which I'm the president-elect for, which I'll tell you a little bit about IFHIMA and our role, I guess, in supporting ICD-11 implementation. So IFHIMA stands for the International Federation of Health Information Management Associations. And we have been around for as long as I have, actually. We've been around since 1968. So we're 53 years strong and still going as an international association. And we provide a forum for exchange of information among our member nations. And we act as the global voice of the health information associations in many countries around the world. And for very many years, we have also been a not-for-profit, non-governmental organisation in official relations with the WHO, and that is something we're very proud of. Robert mentioned the Family of International Classifications network that he leads, and our members participate in some of the subcommittees of that as well. So we have our mission and vision, and our mission is that we represent and advance the global health information management profession, and that our vision is that a healthy world is enabled by quality health information, which I think is very consistent with the things that Robert has said about the need for good health data for improving health outcomes. We have 22 member nations, and we divide our association up into the same WHO regions. As I say, 22 member nations from around the globe. We also have about 120 individual members, 4 corporate members, and 4 educational institution members. So we represent a very broad range of health information managers around the world. Now, maybe many of you haven't come across health information managers as a profession, because we've been often hiding in the basements of our hospitals over the years. So we started out originally as medical record librarians, and then we were medical record administrators, and more recently have changed the profession's name to health information managers. So we have a statement of what that is, and that is that our role is to focus on the acquisition, analysis, and protection of health information necessary for improving healthcare quality, safety, privacy, and efficiency. And HIMs often bridge the gap between the clinician, the operational and administrative functions of the healthcare system. Traditionally, we have been the custodians of the paper medical record, and now the managing electronic medical records. And I guess in relation to ICD-11, the reason why we are so interested in this is that we have traditionally also been responsible for and trained in clinical coding of those records for admitted patient care settings. So as a patient is discharged from hospital, their discharge summary is coded, morbidity coding for those records. So that is why, as an association, we are so interested in what WHO is doing with the ICD-11 and helping to support that. So because of that, we, in early 2020, initiated a working group to write our latest white paper. And the latest white paper is titled IFHIMA Fosters Planning for ICD-11 Adoption with Global Case Studies. Now, this paper was written by a group of individual health information managers from around the globe and is a really good at highlighting, I guess here in the table of contents, how the ICD-11 development was undertaken, some of the content and characteristics of it, some of the benefits. There are adoption and implementation strategies outlined. Some of the unique challenges and opportunities for developing nations are mentioned in here, and it finishes with a call to action. The case studies that are in the white paper specifically look at some of the country environments in which, for example, much of the field testing of the use of ICD-11 for mortality and morbidity coding was undertaken, like in Canada. Some piloting of implementations from the Eastern Mediterranean, a case study from Japan on ICD-11 planning, who have done a good work in translation. Also the Spanish translation case study, and some case studies around the Education Implementation Committee work that IFHIMA has been involved in. We've also, and forget the detail of this slide, I guess these next two slides are some infographics that we prepared that actually summarize the white paper content that we can use to help not only health information managers, but others who are interested in the ICD-11 and planning for that at national levels, understand at a high level with simple infographics that what ICD-11 is about and the benefits of moving to that in the future. We also have a lot of interest in ensuring that our member countries and those who are not even our member countries have the information at their fingertips that will allow them to plan ahead. You know, we understand that you know, many countries are not able to implement ICD-11 straight away, but we know that it's a journey we need to go on. So I guess from IFHIMA's perspective and the role of health information managers, you know, the question is, why would we want ICD-11? And Robert has outlined the fact that it does have over 80,000 codes in its foundation, and it does support the use in many different healthcare settings. It now covers things in much more detail, like traditional medicine, and much more detail in the specialties. It also can, as outlined, be integrated with the ICHI and the ICF that Robert mentioned. It has language translations that are available now and others in the pipeline. It's a web-based design also, which from my early coding days, we had hard copy books sitting on desks. So the world has moved on since then and takes advantage of the new technologies available. The structure is very flexible, and it is designed for use in more than just admitted patient care settings, as outlined. We, in Australia and many other developed countries, have developed local modifications, and IFHIMA is of the belief that this will no longer be necessary, that we would be able to use ICD-11 in its international format for use in national implementations. So as mentioned, Australia has the ICD-10 AM, the Australian modification, and the current thinking is that we will not need to develop a national modification for the future, that ICD-11 in its foundation will contain all of the codes that we will need to replace the national modifications. It certainly, also as Robert outlined, has brought forward some dramatic medical and technological advances. So much of the terminology that was used in ICD-10 and its predecessors was very old language and very clinically out of date. So the new ICD-11 gets rid of all of that old language and brings things through for modern medical terminology. The structure does allow us to continue to talk with the terminology's environment, and WHO has mandated the use for mortality from January 2022, but for morbidity, I guess many countries are on a very long journey to consider just how it will be best applied within their country contexts. So IFHIMA has recently been meeting at our board level with some other special interested individuals to try and see how we could plan some activities that we would do over the next 2 years to help our member countries as well as other countries to plan to adopt ICD-11 for the future. So one of the things that has really come to the fore is the need for education for our individual member countries and our other members. So we are planning to assist by developing things like podcasts, webinars, conferences, the infographic that we've just highlighted, and other social media. We'd like to also make available tools to assist countries to implement, which we can incorporate. We're redesigning our website. We want to be able to partner to redistribute tools being constructed by WHO and others through that forum. And we also want to know that we're going to be a global voice to make sure that ICD-11 is implemented in countries as they're able to, and provide that role of a bit of advocacy within our countries and the member countries for which we represent. So I'll finish up there. We, as I say, are an international NGO in official relationships with WHO. We also have an association with IMEA. We really do want to assist those who are interested in implementing ICD-11 to do so in the future. So please feel free to subscribe to our global news or check out the IFHIMA website for more information. So thank you.
Thank you very much indeed, Vicky, for this talk, which shed a lot of light actually on IFHIMA and how it is supporting the implementation, planning, and all that of the ICD-11 in collaboration with WHO. And of course, Dr. Robert is on top of that as leading the network, the global network for that. We have a few questions that we would like to pose. And between Vicky and Robert, you can do that. So the first question actually is the relation between the two big classification or terminology standards, the SNOMED and the ICD-11. Is there a bridge? Is there a collaboration? Are they actually connected? How does that work, Robert?
Well, thank you for this important question, Najib. And we're also receiving this frequently from other sources. And as you know, in the resolution, the member states requested WHO to support the implementation in countries. And now there is a whole range of, not some high resource countries that are using, in that case, SNOMED-CT together with ICD and other systems. And as part of this kind of support, of course, we are also looking at building links between the systems. Originally, it was planned during the revision process to establish these links, but there were different obstacles over time that came into place. So we will need to do these links after the fact. And actually, we are working to set up a pilot that will look into crosswalks to the foundation of the classification, not just to the statistical part, so that countries then can decide whatever system they want to use, but they can losslessly convert from one system to the other without any problem. Because why this? Because let's say the high resource countries with sophisticated systems take more time to move on to ICD-11, whereas the lower resource countries that have simpler systems or no systems happily are moving quickly to ICD-11. Accordingly, the world map looks a little bit different from what it normally does. So the low resource countries are leading in this. And this means they usually start with ICD-11 because it's just so much easier to start with. And then with this crosswalk, one can then later decide also to take advantage of special features of the SNOMED system. Back to you. Thank you.
Thank you. Thank you very much indeed. There's another question actually on the implementation plan of ICD-11 with respect to training of providers and or the coders. Is there a plan? Is there collaboration with regional offices, the NGOs in official relations with WHO, with the collaborating centers, so that people get the training on that?
So there are many collaborations. There is also a set of webinars that WHO is conducting directly for introduction to ICD, and whoever's interested just send a mail to icd@who.int, so we can put you on the list. But the other thing that we also discussed with our colleagues from the IFHIMA is that we want to organize really online hands-on training. And at the past, we had a little bit of hesitation, not sure how this may be working out. However, we recently had one country hands-on training with about 150 participants, and it worked very well. So we are confident that we can train the trainers together with IFHIMA online, and also, of course, with other partners, whoever wants. And if a country asks us, we will also support. However, if we have to train every country individually, we are having some 200, that may be very tough. So we try to group this, of course. Back to you.
Thank you. Thank you very much indeed. There is a third question actually in terms of the burden that the implementation of ICD-11 will bring on the providers. Will that actually add more work, or it will help people to manage information in a better way?
So well, the burden thing is a how to say, also an advantage, is a return of investment. And the core question is, where is the burden? Of course, existing IT systems need to be updated to be compatible with the ICD-11. You have seen my presentation where I was saying, don't start importing lists of ICD codes in your system to do the coding. This would be bare nonsense. And even if you use other interfaces, you don't know whether the coding of the same disease entity will be the same using this different synthesis. It's compromising the data collection. The burden will be much less for the health providers, because with the design of the ICD-11, the goal was also to have something that is as easily as a Google search for coding. And this means that essentially with near to no clue of the ICD, you can still get good coding results. And with a little bit of an instruction on what these things mean on the coding tool, you can become really good. So the number of intensive, extensive trainings will be reduced to a very few high-end experts that eventually solve special problems at national or international level. The normal user essentially can continue to use ICD. And one thing we should bear in mind, we have countries that are greatly organized, that always had ICD trainings, but there are many other countries where people got book on the table and say, now we are using the ICD-10, go ahead. And then you just try to find your way. And that's the reality in many countries. So, and with the 11, it will probably happen the same thing, but at least then we can be more confident that without further instruction, the coding results will be much, much better. So back to you.
Thank you. Thank you very much, Nadir. Can I ask Vicky about the globalization of the ICD-11 in terms of language versions? It was mentioned that, of course, the terminology and everything is available in English, and then there is Arabic, and then there is German, and so on. Is there any specific effort that you are making to support language versions? We know that the world is very much diversified. English, French, Arabic, Chinese, Russian, Vietnamese, and so on. So is there any effort? What do you do with that?
Yeah, many of the collaborating centers, and Robert may know this better than myself, but many of the collaborating centers that are in different countries with different languages have undertaken significant bodies of work for translation. Certainly, there are some well advanced and others in development. Perhaps, Robert, you probably know more about how many languages we're up to now?
Well, at the moment, we have an official release these 4 languages that were mentioned earlier. We'll soon activate a French version and a Russian also during the course of this year. And on the platform, we have currently some 20 more languages that are at different stages of progress in translation. To be mentioned, maybe particular Portuguese, that is relevant to many countries also outside Portugal, of course. But as I say, we have some 20 on the platform. Back to you.
Thank you very much, Robert. Now, we know that ICD-11 is to serve the digital environment, and we have so many countries and so many institutions, actually medical and health institutions, that are lagging behind in terms of digitization and in terms of electronic files and all that. How does the ICD-11 contributing to the digital gap, or trying to bridge it, or trying to do something about that? What would be the solution for institutions that are not up to the maturity level that we expect in terms of utilization of a system like this?
Well, so we have the point that Vicky was so lovely to explain earlier, that those who transform what the doctor wrote into some coded content sits in dark rooms in deep cellars of hospitals. And frequently these hospitals don't even know that there is a computer where they work, even in low resource environments. And so we are very confident that the 11 technology can also be used in these kind of very low resource environments. And certainly we may have facility levels in remote regions where eventually even paper is a scarcity, not to talk about electric power, sustainable, available all the time. In this case, it's still possible to use a print version, but I would also then say, let's see what is the range of conditions dealt with, eventually even what we called in the ICD-10 a cheat sheet, so a simple list of the few things that are being dealt with would help in this context. So you're not forced to use the digital environment with ICD-11. The main thing is really that we wanted to make sure that if you are having the kind of digital scale up of the country, the classification system can follow and provide the information that, well, policy, reimbursement, and also patient support needs for health. Back to you.
Thank you very much indeed. My second question, or the question is, what would be the major 4 or 5 elements of a strategy to move from maybe ICD 9 or 10, or no ICD 10 or no ICD 11 into ICD 11? What would be the advice for countries to follow? If you can provide an advice.
Well, the main point will be to have a clear political decision that this is going to happen now, and to bring together all stakeholders and inform them about this, inform them about the structural changes, and make a national plan. We have designed this implementation and transition guide exactly with this in mind, where we have one part that gives a little bit of information of the ICD itself, and the other part we have worked upon with multiple partners. So with IFHIMA, with collaborating centers in countries like Australia, like the US, like Japan, and others, to see what questions come up usually when you do this implementation. What are the good steps? So, and we have a scheme there that allows you to look at and say, which are the information systems that need to be checked for impact of the new classification systems? What are the IT aspects? And at the end, we even have put a kind of template implementation plan that says that, well, if you are firmly decided and you do not need to make a translation, you can go step by step to the ICD-11. Of course, this will really depend on the individual country, but I think the one very essential parameter is that there is a national, clear start now decision, and that there is also close link with the digital health or e-health authorities that have been created in some countries, that some of them are very well aware about ICD and linkages, others are not so much, but some work we also need to get together with IFHIMA and also with IMIA to create, to strengthen this kind of links, so that this works together and not data streams on one side and informatics on the other side. Back to you.
Thank you. Thank you very much indeed. You did mention that a number of use cases have been developed in different regions. Can you pick any of them and a little bit of description of what went into that particular use case in terms of using ICD-11?
Well, so the core use cases is number one, the cause of death information, and the other one is, of course, the clinical documentation in the context of reasons for encounter. And so for causes of death, I think we had an early test in with an electronic death certificate generated in Lebanon, and then in Africa, in I think it was Uganda, the decision was to start an electronic death certification system in collaboration with several partners that do the civil registration, and where we have provided guidance on how to design this and how to incorporate the coding engine into this kind of certificate, so that the documentation and coding can be much easier. They have electronic record systems in Tanzania as well as in Rwanda. Yes, Rwanda, that have integrated the ICD-11 already. Also, Kenya is working on this. Not to forget that practical clinical use in an implementation pilot is running, for example, in a major hospital in Kuwait, and clinicians are happy. And I think the biggest population systematically covered is the Palestinian one of the UNRWA, that essentially is running their whole primary care information system with ICD-11 and is producing data. And it seems the end users are very happy with limited training, getting good quality and finding the clinical content they want. And this will be expanded also to the other information systems that are used in that context. Of course, Egypt, for example, as using ICD-11 for their newly designed reimbursement packages for health provision to the population, and similarly in India. So there are many other initiatives. China has given a government order that ICD-11 implementation starts, and some major hospitals are already using it. So this is what is happening, but I think the most exciting are the practical use. And I nearly forgot Namibia, that has the first national data set completely coded with ICD-11, a full year of data. So we could even use this to test our new platform that can assess the data quality in mortality, the new ANACOD 3 that we have been recently launching. Back to you, Najib.
Thank you very much indeed. For the last 2 years or so, we have been facing this pandemic, Corona and COVID and the rest of it. Has there been any response from ICD-11 family of classifications to that particular virus and disease, and the lockdown and people not being able to travel, to not to go to hospitals, people dying, and mortality is increasing, and also the different issues that people are facing? Has ICD-11 been up to that to deal with these issues?
Oh, there's a simple answer to this, and this is yes and no. Because, well, as I just said, there are only maybe 2 or 3 countries that start producing data with ICD-11. And of course, we have the code sets available to encode all this information. Same way, of course, we did for the ICD-10, so that the many countries that are still using ICD-10 can continue these diseases. And I forgot to mention in my earlier list, actually, Belize, who is also doing an excellent job in the implementation of ICD-11. But back to the COVID, yes, so in a way, it's all there, but it's not yet so much used in many countries. And but I think it has been very helpful. Back to you.
Thank you very much indeed.
We should maybe mention that, of course, ICD-11 is the code set that WHO is also recommending in the context of the vaccine certificate for COVID, and also in the broader one, so that some people were saying, oh, why do we then need to switch to ICD-11? Said, yeah, what else do you want to use? There is nothing yet in place. And of course, SNOMED users can continue to use SNOMED, but others, they don't need to implement expensive systems. They can just go ahead with the ICD system and prepare their migration this way. Back to you.
Thank you very much indeed. Is there any question or comment from the audience to both Dr. Robert and Ms. Vicky? Well, if no question, and I cannot see any question actually on the question and answer or the chat, thank you very much indeed, Vicky. Thank you very much indeed, Dr. Robert, for this insightful and very, very useful description and analysis of the ICD-11 and the stages that have been taken, the steps and the different endeavors and the different countries' uptake of that. And what we hope is actually that countries will take it and will use it and will enrich the terminology by adding the national languages, by adding terminology, by suggesting. And I'm sure the team in headquarters and in IFIMA and in everywhere, they are in listening mode to learn from the hospitals, from the countries, what they need and what they suggest to them. So thank you so much for the presentations and for the discussion. And we look forward to more use and more extensive utilization of the tool. You did mention actually the Palestinian implementation of that. I have been advising actually NERWA in the development of their family e-health system located in Amman. And thank you again for the workshops that you have been doing, and they are taking it very seriously and integrating the ICD-11 into their system. So thank you very much for all the effort that you have been doing. I stop here, and then I want to introduce Dr. Louis Jepper for inviting us to Australia. And we did actually, quote unquote, manage to step the coming to Australia last August because of Corona and because of COVID and because of the embargo and all that. but I don't think in 2023 you will be able to do that, especially that COVID is hopefully going away. More countries are lifting the embargo and lifting the different limitations that they have been putting on people in terms of travel, in terms of going out, and in terms of opening up meetings, conferences, and all that. Tomorrow, I am actually a chair of another international conference, and the instruction came to us actually this afternoon saying that tomorrow we need a little bit of social distancing or physical distancing. We need to have masks, and we are observing to make sure that everybody has got the vaccine, which we are ready for that. So I hope in 2023 we will be ready, and the pandemic will have gone, and it's part of the history. So Louise.
Hey Najib, it's lovely to see you. Man, I miss you guys. Does everyone feel the same? Man, it's just yes, it's who knew what life was going to be like, you know, come this year. So thank you for the introduction, and I'm really pleased to be able to join you. I'm going to pretend I can see, you know, hundreds of people staring back, smiling, and I would know most of your names. But at the moment I'm just obviously looking at myself and Najib. So I thought I'd prepare a little bit of a talk and talk you through what's been happening down under. So bear with me, and I'll share my screen. Okay, it's just coming up. It's always good when things are live, isn't it? Okay, where did it go? Sorry. Thank you for your patience. Hang on a minute. I see what's happening here. All right, I'm going to try something else. Okay. Okay, now let's try this again. Okay, right, you should be able to see that now, which is just the MedInfo holding screen, and hopefully you see my face as well. Elaine, I'm looking at the chat, so if you can't see me or something, let me know and I'll try and work out. Okay, so I thought I would I'd take you on a little bit of a journey of what happened since I saw most of you last, which was in Lyon at the end of 2019, when life was very different back then, wasn't it? Some of you would remember that we were in the process of going out to our membership here in Australia and asking our members and fellows to vote to merge our two health informatics bodies. So there was the Health Informatics Society of Australia that many of you would be very familiar with, and a lot of you would also have involved with the Australasian College of Health Informatics. So we spent 2 years talking to our members and trying to convince them that merging the two bodies was a really good idea. And I'm very pleased to say that with the exception of maybe 3 people, no, everyone voted yes. Like, it was an overwhelming support for the merger. And we needed an overwhelming support for it to go ahead. So that happened just after Lyon, actually, in December 2019, and the merger went through, and we had a launch date of February 2020, and so Christmas was cancelled, and we spent a lot of time building a new website and a new company structure, and we renamed ourselves the Australasian Institute of Digital Health. And so we did a lot of work on our branding and all those things that you do when you set up a new company. We really liked our tagline. We had t-shirts made, healthier lives digitally enabled. We had a party. Now, point out that this was pre-COVID, so there was no social distancing, no masks. At this stage, COVID was something that was happening in Wuhan, and everyone was thinking, God, how terrible. How do you shut down a city? How would that, I don't even know, how would that possibly be possible? So we were too busy. We were partying and launching. We all had, you see in the photos there, we all had our t-shirts, and we had a really good time launching, and we had a new strategy as well. This was the incoming board, the staff were excited. So 3 weeks after this launch party, this happened. And so these are just some key dates. So we launched on the 24th of February. 3 weeks later, on the 10th of March, the Premier of our state, Victoria, here in Melbourne, was like, oh, this is coming, this is a problem. Not long after that, a state of emergency was declared, and then we went into quite significant lockdown. We closed down the Institute's office on the 13th of March, 3 weeks after we launched. Since that time, I haven't really spent much time with my staff in person, because Melbourne, unfortunately, yesterday hit we won the world record for lockdowns. And so we have been in lockdown on and off. We're in our 6th official lockdown here in Melbourne. And so we've spent over 250 days now, all on our own, locked in our homes. We have a curfew. We wear masks everywhere. And the reason that, just so this is the bad news, don't worry, I'm getting to the good news. The reason for the lockdowns is because, for those of you who might not be aware, Australia had a really different approach to other places, and we were fortunate in being able to shut our borders, like literally shut them, because we are an island, and like New Zealand, we're far away from everywhere else. So we were able to, so our governments moved very quickly to shut our borders. At first it was to a couple of countries, because back in the day when we thought this thing might be able to be contained, but quite quickly we shut all of our borders. So like Najib, I've been invited to speak at numerous international events, and I've had to say, sorry, I can't come, because other places, I know you guys are, some places of the world are able to travel. It's just not an option for us. Our Prime Minister did say earlier late last week that they're hoping that the international borders will be open before Christmas. So I might be able to, come to Dubai or France or somewhere like that for Christmas, but I probably won't be able to get home to Perth, where I'm from, on the other side of Australia, because they have a very significant lockdown. And you'll see Sydney, unfortunately, our friends in Sydney are also in lockdown at the moment. They've been in lockdown for just over 100 days, I think, and it's their first significant lockdown. The good news is, though, that because we've had these lockdown measures and mask mandates, while we were able to catch up with vaccines, because we had an issue with vaccine rollout here, it's a whole other political thing which I won't get into, but our vaccination rates are getting there. So now Sydney is on track soon to reach 90% double dosed. Victoria is at, I think we're around 80% single dose right now, and by November, sometime in November, we should be on track to hit the 90%. So our government mandates our roadmaps out of this. That means that we will get out of lockdown very soon, and the good thing is that while it's a challenge being in lockdown, as you could imagine, and I know a lot of you would have been in lockdown where you're from as well, so that's obviously very challenging, but the upside is Australia has had very minimal deaths from COVID, which is something we're really proud of, and by keeping everybody and each other safe. So, but we were busy. So even though we're in lockdown, you think we actually had more time. So the Institute were really busy. This is our new strategic framework. We've really highlighted our work and really targeted our efforts around building workforce capability. And we see that as not just having the profession of health informaticians and making sure that they have career pathways and resources to improve in their skill sets and also have the recognition. But also we see the workforce as there's everybody else. There's, literally hundreds of thousands of people who work in the healthcare sector who don't need to be health informaticians, but what is it that they need to know about digital health to be the best physiotherapist they can be, to be the best nurse they can be? So that's a lot of our focus has been on that, as well as engaging and growing our community and being leaders, especially in this time where the momentum behind digital health has really grown. Our certification program, a lot of you would know that we, many years ago, we launched a health informatics certification. That program has just been so successful. We now have way over 1,000 people who are certified in health informatics, where a lot of the growth for that program is coming now is not just from individuals who are saying, hey, I'd like to be recognised for my unique skills and abilities, but we've also getting it now for employers, which is really exciting. So employers are really now recognizing that not only do they need to support their own employees, but they need to build a workforce that is health informatics literate, that has health informatics specialists. And so we've got a lot of employers who are signing up. Some are doing hundreds, others are doing 20, 25. Everything is great. So that program's been going really successfully for us. Some of the other things we've been doing in workforce is that we have a fellowship by training program. This is particularly for PhD students. So if you're undertaking a PhD, you enroll in this fellowship by training program. You undertake a series of informatics related activities and work projects and mentoring through the Institute. And you graduate not only with your PhD, but if you complete all the course requirements, you get to be fast tracked into our fellowship program as well. We also have a new program for executives. So traditionally, our pathway to fellowship that we inherited from the College of Health Informatics was more centered around a lot of EMEA type people like you guys who have PhDs and who work at universities and who've spent your entire careers dedicated to health informatics. But of course, there's a lot of people who may not have pursued academic pathways, but have still progressed their professional development and have significant responsibilities and decision-making roles in the healthcare sector. So we built a framework for those people to have a more executive and managerial pathway into our fellowship as well. We're in the process of building a foundational digital health program, just a digital health 101 is what we're calling it. We've also, that one will be out later this year. We've built a program for board members. So people who, again, if you sit on a health board, what do you need of a hospital, let's say? What do you need to know about digital health to do your job really well and to execute the decisions that you need to make that are around digital health? And we're very excited that and this is hats off to Wendy Chapman, who many of you would know Wendy. When Wendy was in America with AMEA, her and a group of people started Women in AMEA Leadership Program. And now that Wendy is in our lovely city of Melbourne, isolated city of Melbourne, but still lovely. Then she brought this idea to Australia, and the Institute have really embraced it. And we've managed to get corporate sponsorship. So next year will be our first cohort of women to go through this targeted leadership and mentoring program. So we'll be able to talk to you more about that, but that'll be launching officially next year. We're really excited about that. We did this work, which some of you may be aware of. We were asked by the Australian government to build a national nursing and midwifery digital health capability framework. So again, the essence of it is, what do nurses and midwives need to know about digital health? So we built this framework in conjunction with a lot of really important nursing and midwifery bodies here in Australia. That project lasted for around, say, 12 months. We have this framework that has been published in the academic literature just a little bit. Actually, we have to do better at getting it into a journal. But this information is available. If you just Google it, you'll find it if you're interested, or there is a link to the government website there. What was really cool, though, is this framework wasn't just embraced by the Australian nursing and midwifery community, but Ireland knocked on our door, like the country, and Northern Ireland and Ireland came, and we ended up working with them. And so they've actually adopted what was built for the Australian audience, not just for the entire continent, for them, but they've also, they're looking to expand it into actually being a framework that is used for all clinical professions, which is really exciting. There was a presentation on that at the Nursing Informatics Conference as well about our collaboration on that. So we're really pleased to see that that's been embraced at a global level, not just here in Australia. We put out this paper. There is a link there to it, but again, Google it, you'll probably find it. It is on our website. We wrote this paper about what is digital health and why does it matter. My colleague David Rowlands wrote this paper, and it's a really fantastic piece of work. If you haven't seen it, I recommend you check it out. At its central thesis is that before digital health, so before, recent times, a lot of the work that we had done was applying IT systems into the healthcare sector. First, there were systems that weren't built for health, but we adapted them for health. And then we started building systems that were specifically for health. A lot of the electronic medical records, for instance, started as billing programs and now are really comprehensive clinical care records. But the central tenet of this paper is really looking at, when we use the phrase digital health, what we're really looking at is no longer about the application of technology into the healthcare sector, but how does the healthcare sector, need to evolve, need to exist in a digital society and in a digital world. And that, if you think about it that way, it really flips the whole tenet into really what does health need to do in this digital world that we exist in now. And that will give you different answers than just what problems does the healthcare sector have that technology can put in place. And I see in my periphery vision there that Elaine has put up the link to the paper. Thank you, Elaine, you're awesome. Thank you, Elaine, for doing that. So if you're interested in checking out that paper, please do so. We launched an entirely new network within the Institute called Ingenia. Now, Ingenia is the Industry Genomics Network Alliance. And what Ingenia effectively does is it brings together industry, so pharmaceutical, IT, biopharmaceutical, medical devices. So a bunch of companies who are interested and have their own interests and pursuits within the field of genomics, who recognize that genomics isn't just about looking down at the microscope, as I like to say, like the science of genomics. We're really interested in the information management part of genomics. We're about to get this massive data deluge of genomic information, and there's not many places in the world that have come up with a way to do that and integrate it so that access to genomic information is available as part of everyday healthcare. And so this network that the Institute runs on behalf of Ingenia's members is really about bringing that, what can industry do to really raise the issues and see progress in this matter, and learn from what we've done in digital health for all of these years and informatics in all of these years. So that's something new and exciting as well. I said we have been busy, and we've had so much interest. You're not supposed to be able to read this slide, and next year when I show this version of this slide, you really won't be able to read it, because this is all of our fellows and associate fellows. Well, actually, it's from a couple of months ago, this slide. So if you are watching this and you're a recent fellow of the Institute, you don't see your name there, I apologise. But we are getting interest pretty much every week from new people who meet the eligibility criteria and want to become fellows of the Institute, which we're really, really pleased to grow that community. We also have a bunch of organisational members. So the Institute, we have organisational members as well. This is actually, organisational membership is actually one of our fastest growing areas. And we've encountered a new problem, one of those problems that it's nice to have, where we're getting a lot of health services come to us now, and quite large companies as well. And they don't want 3 people, 3 employees to be members or 5 employees. They want 50. And we actually don't have a membership structure that allows for massive groups of people to join at once. So we're solving that problem now. And as I said, one of those nice problems to have. But again, it's fantastic to see locally here in Australia, and I hope you're seeing the same thing in your parts of the world, of just how much momentum and interest there is around what we have been doing for a long time. And some of you on today's call have been doing it for way longer than I have, and hats off to all of you. Of course, we held the Nursing Informatics Conference. This was supposed to be our highlight of 2020, and that didn't happen. COVID had other plans for us all. So we were really pleased to work with EMEA and the international community on bringing Nursing Informatics 2021 together. And we held that as an online event, and it was really successful. And all the videos are online as well. So anyone who registered for that conference has access to those videos to watch them back. So that was really successful. And now, of course, for the Fiesta Resistance, MedInfo 2023. So, as I said, we have all been through tough times, and they're still going through them depending on where you sit. But, things are looking up, and I can tell you that there is so much interest in bringing international events to Australia in 2023 that we actually had to fight for this space because, originally we booked space as part of our bid which was going to be 2021, of course, but thanks to EMEA and thanks to Taiwan, arrangements were changed so that we are now running MedInfo in 2023, as you know, and Taiwan doing the following MedInfo. But we had to fight for this space at Sydney because there's so much interest. So people are really looking forward to being able to get on planes again. We'll probably still have to wear masks on planes even in 2023, I imagine, but there won't be lockdowns, and we'll have a globe that is highly vaccinated, and there'll even be better vaccines by the time 2023 comes around. So I just, on behalf of the Institute and the board and all of our community here, I'm so excited and thrilled to be able to welcome you all in 2023. I can tell you there won't be any social distancing because even though I don't know you very well, you're probably going to get a hug from me because I'm always so excited to not just bring MedInfo here, but to see all of you in person and to be able to really celebrate this international community and to be able to bring you together. I know there was requests for barbecue dinners and stuff like that. And so we will work that out. July, even though it's winter here, it is Sydney, so the weather's pretty nice usually. So we will work out social things and fun things to do. There is going to be a fantastic program because MedInfo always has fantastic programs. My staff are really keen. You will see the call for papers, which will be coming out. I don't know the exact date actually, but if it's not later this year, it'll be early next year for that. So keep your eye on the EMEA newsletters and the Institute newsletters for that. And it's going to be so wonderful to see you all. And I really look forward to bringing you and welcoming you to Sydney in 2023. So back to you in the studio, Najib. Thanks for having me here this morning.
Thank you. Thank you very much indeed. Thank you, Louise. This is fantastic. You have been really busy over the last months, not stopping work because of COVID or because of any of these lockdowns. So thank you very much indeed. We do look forward to seeing you in 2023 in Sydney for the MedInfo. And I'm sure so many people are eager to be there and to join you in Australia and Sydney to enjoy the weather and to enjoy the place there. So we do look forward to that. Thank you very much for the fantastic presentation and the different activities that you have been doing. This is really inspiring. Although our the Academy president is a little bit confused between digital health and health informatics.
I can answer Bill's question if you give me a second.
Yeah, please do.
And yeah, thanks for the question, Bill. to tell you the truth, this was a hard one. There are people who don't have health informatics backgrounds in our field. Obviously, that happens globally. And I was really worried, I have an academic background in health informatics. There was a few of us who were really worried that if we didn't use the word health informatics in our name, that it would confuse people, or people wouldn't realize that just because you've invented an app or you installed an EMR at your hospital doesn't mean you know about health informatics. No disrespect to those people, but our field is this wealth of knowledge that's always growing, dating back to the 1950s or something, depending on how far back you technically want to go. And so we did worry about that, and there were conversations about that. In the end, the reason we went with digital health over health informatics was that we thought that health informatics does confuse people, and we know that this is a problem in other countries. It's not just in Australia. For people who haven't drunk our Kool-Aid, it confuses people. It's not a term that they're familiar with. So we thought, well, if we go with digital health, which our governments are starting to use in Australia now as well, they still use e-health a bit, that we would hopefully, it would remove that barrier for those people. For the health informaticians, then we might be a bit like, get our nose a bit out of a joint about it, but we still know what it means, right? So, but we thought if we lower that barrier to entry, would it help? And we weren't sure, to be honest. So it was a bit of a gamble, but it has paid off for us. So we are finding, people are finding us through Google searches, and the term digital health now is become quite synonymous. So once we get them into the community, then we teach them about health informatics. And so we want to encourage more people to, to study informatics at a university level, and to really recognize this wealth of knowledge and expertise that has come before them. So it has paid off for us. I know it might not be an approach that works for everybody, but it is something that we were cognizant of, but it has worked for us. So thanks for the question, Bill. I hope that's an okay answer for you.
Thank you, Louise. I think it was in an editorial. I think it was after the WHO resolution on the global health strategy, in which the title of that editorial was, I think it says, "Here we go," which means actually that people are inventing terms and concepts and all that, but it all goes back to using information and communication technology for the betterment of health of people. So
yeah, that's right.
with the term, and I'm sure it will be aligned, it will be mapped, and people will understand it after a while.
Yeah, well, it was very important. Things like our certification program, which, as I said, is really popular. One of my staff, who is a marketing person and not an informatician, was like, "Oh, why don't we change its name?" And I'm like, "No way!" It's health informatics. We still have to talk to people and teach them about health informatics. So yeah, we make sure that we still use informatics. It's just not in our name. So yes, thanks for the question. All right, well, I should hand back to you, Najib, for you to wrap up the rest of the proceeding.
Thank you very much. Thank you very much indeed. In fact, the intelligence and the flexibility and the care about the globe is actually working very nicely within EMEA and within the different communities globally. And having this one actually as a virtual or as online conference as MedInfo, postponement of Australia until 2023, and then for Taiwan to be in 2025. All that has taken a little bit of discussion and consensus building and acceptance and all that. But I think the care about we want really to do something that is useful to the world, that is useful to the global community, has paid off, and everybody became happy with this arrangement. At least I'm very happy, and Elaine and Sabine and the rest of the community, they are very happy with this arrangement to have this conference as a virtual one, and then 2023 in Australia back again, and then in 2025 we go to Taipei, Taiwan. So the last thing for me to do is to invite our president, Sabine, Dr. Sabine Koch to say a few words on the closing of this conference and this session. And then the last word would be from our President-elect, Dr. Jack Lee. So Sabine, would you like to say a few words on the closing of this conference and this session as well?
Yes, of course. Thank you, Najib. And first of all, it was not so nice to see you, Louise. I could jump right over into your screen. You did such a great presentation. So I think everybody is now thrilled to go to Sydney. And because of course, we all long for physical meetings, and we know that you are great, great hosts in Australia. So I'm personally very much looking forward to MedInfo 2023. But as you said, Najib, also, we had a really enjoyable experience now with our small scale virtual MedInfo. We had the aim to give the presenters a space to publish in PubMed indexed proceedings, and we can do it thanks to the long-term collaboration with iOS Press. And we especially wanted to have a broad participation and enable everybody to come to the conference. And we could keep these few interactive parts and give everybody free access to the live panels and also to the presentations that will be online soon. We didn't want to have whole day virtual meetings because we all suffer from screen fatigue by now, probably. But I want to just quickly wrap my reflections over the 3 years, 3 days, excuse me. I thought we had a really nice flow. The François Grémy Award lecture with Ted Shortliff gave quite a new implication on the concept of TED Talks. We had great experiences from Taiwan and Buenos Aires about how they handled the COVID-19 pandemic. And I think this was one of the great things with the panels, that we tried to make good diversity when it comes to different regions. So even the maternity and child health panel was great with contributions from Africa and Asia and South America. Then we got the WHO regions to talk about the different digital health strategies, where I think we could learn a lot about our similarities and differences and which prerequisites we have in different countries, not least regarding privacy. Privacy security was also an issue when we discussed interoperability in the standardization panel and how we achieve collaboration supported through standards. Today, we had a really great panel by the AFME working group on One Digital Health, which actually I think right off lifted the previous panels to a new level. And now today we heard about the developments in ICD-11, which was also good to see where they are heading and what the state is today. So it was utmost valuable to see how we deal with our similar problems in different contexts. And I hope you could all learn a lot, even if we had it virtually and we perhaps cannot connect in the same way we are used to, but we will make up for that in 2023 in Sydney. So it was a great event, but we could only achieve it thanks to the hard work of really a number of people. So I will take a second to share a slide here. Here are the main people I would like to thank, and it's Najib Al-Shubaji as the VP MedInfo. I just have do you see just the slide? Because mine is covered, but I hope it's okay for you.
Yours is covered, Sabina. I can only see. I don't know what the audience sees though.
No, it's covering.
Yeah, it's
the
covered
slide
by
is-
your videos.
Yeah, which is strange.
Maybe you can minimize
I
it.
try to.
Try it again.
I try it again, simply. No, it always pops up there.
You need to share a single window rather than your whole screen.
No, it's better, right? So we.
Yes. Yes.
Yeah. So I thank Najib, of course, as VP MedInfo, Paula Otero and Philip Scott as our SPC co-chairs. Then we had also 8 SPC track chairs: Melissa Baisari, Elizabeth Baricki, Andrei Kushniruk, Craig Kushimsky, Guillermo Lopez Campos, Carlos Otero, Rachel Richardson, and Raymond Sarmiento. And we had help with editing and finalizing our proceedings by Susan Martin and Yvonne Bramble. A big thank you to Jeff Keller, our EMEA webmaster, who will put everything online and helped us with smaller and bigger issues during the whole preparation. And of course, a big, big thank you to you, Elaine, our CEO. Without you, we could not have done it. You put it together. You are somehow 24/7, because in EMEA, always somebody is awake. And strange enough, Elaine, one feels that you're always online. I don't know how you do it. You shouldn't, but a big thank you, big hug from all of us. And with this, my presidency will end soon. I will be for about 2 more months until the end of November, and then I will hand over to Jack Lee from Taiwan. And Jack is known to many, but perhaps not all of you. So I give you the word, Jack, so you just can introduce yourself.
Thank you, Sabine. Can you hear me all right?
Yes.
Okay. I do hope that you enjoy the extraordinary experience of the MedInfo 2021 online as much as I do. My name is Jack Lee. For those, actually, my full name is Yuchuan Jack Lee. I'm from Taipei Medical University, and I got a degree from a PhD in medical informatics from University of Utah under Dr. Homer Warner. So I've been doing medical informatics since 1991. It's been 20 more years. So I've seen, very simple, very early hospital systems to the more advanced ones. But as I see the poster and papers presentation, videos accumulate to more than a couple of hundreds in the EMEA MedInfo YouTube channel. It is kind of available now, but it's actually officially available in 2 days. But when I see this video accumulate, I feel excited with expectations, almost like there are loads of new movies making their ways into Netflix. Now I can sit back and enjoy the next couple of weeks with all these 13 10-minute videos. And it will be a feast. After these 3 days of meetings, they're another feast for a couple of weeks that, as informaticians will be happy to consume. And Sabine already mentioned that a lot of people helped the meeting to make it a success. Of course, the key leader is our very own executive officer, Elaine Husing. Even during an evacuation due to a regional forest fire, she persisted and pushed forward the preparation of the conference. Then finally, everything worked out wonderfully. So again, big hands to Elaine Husing. Taking over from Sabine will be a tough act to follow, especially in a challenging time like this. But I hope that the success of MedInfo 2021 online has proven that EMEA is on the right track to its own digital transformation. And we are considering having MedInfo online in between years, in between the physical in-person MedInfo years as kind of a transition. But that's a discussion that's still going on. So consistent to our vision of one world, one health. With all your support, we hope to make EMEA more available to everyone in the world. With some major transformation, we like EMEA to be your key companion to the future of digital medicine and digital health, and of course, informatics. Okay, so see you all in 2023 in Sydney in person and 2025 in Taipei. Thank you. Back to you, Sabine.
Yes, that will be great. And if you share your publications, your papers, and your presentations through social media, just don't forget to use the hashtag MedInfo 2021. And then we are looking forward to see you in Sydney in 2 years, and perhaps on another virtual event that EMEA organizes in between. Perhaps that might happen, we will see. And I really hope you enjoyed the conference as much as we did. Thank you for participating.
Sabina, maybe we could have Paula and Philip and Najib join you on stage here and just say goodbye.
we have to do it one by one after the other.
Yes.
So I give to Philip perhaps.
Yeah, so thanks everyone. Goodbye. See you in 2 years.
It was a great experience. It was more like a roller coaster, but now I don't want to get down from it. It was a great experience. Thank you very much.
And Najib as well, yeah.
Thank you very much indeed for everybody. I think it was a great experience and a great event. And for the last 2 years, I don't know how many times I have participated in teleconferences and Zooms and the Germans, whatever the platform is, and the Microsoft and all that. But this one has a very, very special flavor. It's fantastic to see friends and colleagues and to talk to them and to present and to moderate. I did enjoy it. Thank you so much, Elaine and Sabina and Philippe and Paula, and the big thanks to Elaine, of course. Thank you, Jacob, Dr. Jacob, and thank you everybody for that. I do look forward to Sydney 2023 if I'm still alive, and then in 2025 to see Jack Lee in Taipei, and I do look forward to that, and the journey to learn never ends, and I look forward to that. Thank you so much. Thank you.
Thank you all. Goodbye. Good
Thank
night,
you, bye.
good morning, good afternoon.